So we try to understand why she has set into premature labor.
This journey is not easy. Hi everyone, welcome to BirthVibe by BirthRight. I am Vijayanand Jamalpuri, Neonatologist at Rainbow Children's Hospital, and today we have Dr. Bhavana, who is an obstetrician at BirthRight by Rainbow Children's Hospital, Secunderabad, and we are going to talk about prematurity and everything and anything related about prematurity. Welcome to the show. So, I have how commonly you come across mothers walking to you with the premature labor?
It's been very common, sir, of late. So Rainbow being a tertiary referral center, many times we see premature women coming to take help from us. So we see like around 8 out of 100 pregnant women we see setting into premature labor. And most of the time when they refer to us, it's not exactly established premature labor. Sometimes the peripheral gynecologists, when they see the woman having tightening of the abdomen, before the 37th completed week, that is before the 9th month is over, so they get worried, they get tensed, and they refer to us saying probably she needs immediate delivery.
So in other words, you are saying that it could be false alarms at times.
Yeah, it could be a false alarm, sir. Sometimes when the woman is between 28 weeks to 32, that is 7th and 8th month, the false alarms are very high. So when they come here, we examine them, we do certain tests, we do some monitorings for the baby and the mother both. And then once we understand that they are in established preterm labor, that's when we know that, we are into the prematurity now.
So whenever we come to talk to these families, what happens after the deliveries, one of the big things the parents and the families have is, doctor, can you prolong this? So can we talk about where we can try to extend the pregnancy and so that we can avoid the prematurity as much as possible? And
many times we can avoid premature labor, sir. Mostly 3 out of 4 pregnant women who walk into the Rainbow hospitals with premature labor, we can avoid them setting into labor and delivering premature. But it needs lot of teamwork, as I said, like obstetrician, neonatologist like you, and we have the fetal medicine doctors helping us, and also the nursing team to do the test and everything. And definitely the premature couple, when they walk in, they're very anxious. First thing comes to their mind is, am I going to deliver now in the 7th and 8th month? And what am I going to do? How will the baby be? Though we have a state-of-art facilities at Rainbow, but still the whole team has the protocol to prolong the pregnancy as long as possible in utero.
yeah, I mean the best place for the mother, for the baby is the mother's womb, obviously.
Yes.
And even by nature, by physiology, that's where the baby should be.
Yes.
But there are situations where they need to come out. Then we try to help them if they need to come out. But as a perinatal team, what we call like where the obstetrician, the neonatologist working together, we try to keep them as much as possible. So generally for our audience sake, so what are the ways we can prolong these pregnancies? How do we go about it?
So many times once they enter the labor room, we do an internal examination, we do the CTG, and so we try to understand why she has set into premature labor. So knowing the reason will help us to convince them that we can prolong the pregnancy, or is there an immediate need to deliver.
Correct.
Like you would have seen some mothers coming to your consultation room saying, a doctor has said immediate delivery and the baby is just 1 kg.
Yeah.
So those are the ones whom we need to immediately deliver, like infection into the mother, where mother's life is at risk. There we have to take a call immediately. But sometimes there is no infection and only she's getting tightening, slightly cervical os is open. So we have some investigation tests which tell us that the mother doesn't have any infection.
Correct.
Then definitely 100%, because the mother's womb is the best, we try to prolong, even if it means 48 hours, 72 hours, or a couple of days more based on the mother and baby parameters.
Yeah, I absolutely agree with you. And it's usually it's does carrying the pregnancy cause harm either to the mother or the baby? That's how we think, don't we?
Yes, sir.
And then that is the time baby has to come out. But if it can give us more time, we always try to prolong that. And so sometimes, I mean, the mother is not in labor, but even then we have to deliver this baby to either to protect the mother
Yes.
and to protect the baby, or sometimes both it could be. So yeah, and in that way. But as a neonatologist, if you ask me, when you call us, we are going to deliver this preterm baby, few things comes to our mind. Well, Dr. Bhavana, can you please prolong, because we can look after these babies, but if you prolong for another 24, 48 hours, and we can give certain medicine which help these babies. So, and I know we may put you at times some difficult situation asking to prolong. I think it is possible.
Yes, sir, definitely. When there is no infection, when we call the senior neonatologist also, we tell them like if the mother is stable, we are just going to give her some medicines to prolong the pregnancy. That is tocolytics we give, where we cut down the pain.
Which relax the uterus.
To make the uterus a little more relaxed. Initially, when mother is having pains, that will be the main distress for the whole family. So once the pains are reduced by giving pain medication to relax the uterus, then even the family starts thinking that, okay, fine, the pains have come down, maybe we can go little more into the pregnancy. That's when we call and tell you that we are giving some medicines. At the same time, when the baby is going to be born premature, as most of the neonatologists are worried about the lung maturity.
Correct.
So we give the steroids, corticosteroids. So that would take 24 hours time. So that's only when we know that she is in established labor. Then after that, we ask the couple to see you so that you will explain to them about the advantages and disadvantages, so everything about the steroids. And then once we know that we are prolonging the pregnancy, there will be daily monitoring. When you are asking me this, I remember one of the patients who had come last week at 29 weeks pregnancy, was told to be delivered immediately, was referred here saying so. But now she's almost like 31 weeks now.
Excellent.
So weeks back she came, and we gave her steroids in the first visit itself, because she did have lot of contractions in spite of relaxing the uterus. But they came down after we gave her some pain relief medicines. Then baby is fine, fetal medicine counseling is done, neonatal counseling is done. Now she has come forward by 2 more weeks. So we have gained another 14 days more, and she's still going on.
That's excellent, because every day counts.
Yes.
And as you rightly mentioned, why as a neonatologist we want these mothers to get the steroids, it helps so much make them lungs stronger.
Yes.
And also makes their gut stronger.
So how often are you seeing, sir, women? I mean, sometimes they come directly to the neonatologist for counseling. So this extreme prematurity, what we call it as, before 28 weeks pregnancy.
Correct.
So how do you go about
We see, well, as you know, the Rainbow is known for its perinatal care, as in our unit as well. And we get a lot of referrals. So from all iris obstetrics and very small babies, we would have like, we per year at least 100 extremely preterm babies. So which is, you could say, approximately, it ranges, so anywhere 5 to 10 per month on average. So we have the smallest baby, as you know, 375 grammer.
Yes.
And she's going to school now. And they went all over India to save that baby, because they were told there's no hope. And when they came all the way from Chhattisgarh.
This is the 375 grams.
That's right.
babies.
And 25-weeker, growth restricted, and the blood supply wasn't right. So when they came to Rainbow here, and we did not promise anything, but we said we can try.
Yes.
So we gave hope. I think the hope is the big thing.
Yes.
And so there are several stories like that. There are several stories.
True, sir. But sometimes the woman comes here with a high risk medical condition, like very high blood pressure. Maybe when you look at her, when the obstetrician looks at her, we think that she's going to throw a fit in the next moment. So, and she must be somewhere around 32, 34 weeks. then there'll be a dilemma in our mind, like we are worried about the mother. But as neonatologist, you would be thinking that, it's just a 2 kg baby. If the BP gets under control, can you still prolong the pregnancy is what the neonatologist questions us.
So in the last 2 decades, if you look at, that goes back to my PG days, that tells me my age, by the way.
Yes.
So 25 years ago, I would have not believed that the baby below 1 kilo would survive. But once I went to UK, and my perspective is completely changed. The similar care now is available in a majority of the units, especially at Rainbow,
Yes.
and where these babies do survive, and with the right care, with the right team, in the right place. So certainly we can do good care for them. But having said that, as we discussed, the best place for the baby to be in the womb. But if this pregnancy is compromising the mother's health, if mother is it, because you deal with 2 lives,
Yes, sir.
the baby inside and the mother. So if this mother needs to be saved, of course, you can go ahead and deliver the baby, we can look after. But up to 34 weeks, the even Indian government suggests from 24 to 34 weeks that they get the steroid to get the best outcomes. So the monitoring of both the mother and the baby inside, the fetus, is important until you decide that right moment for both the mother and the baby to come out. Yeah, so I totally agree with you. The variation in the clinical picture of the mother and of course the baby inside, and emphasizing the importance of whether to deliver or not to deliver. And at the end of the day, it's a good counseling and making them to understand about the informed decision. And every clinician is right in their own perspective given the circumstances. That's how I would say. And also it's important, not only the lady and the husband, but the other family
Whole
members.
family.
The important stakeholders in the family is also important that we discuss. But at the same time, we need to tell them the hope as well as the how the course is going to be, because our responsibility is to talk the facts. But not many people are very aware in the community or the society about the outcomes of these small babies. And so even including the medical health profession, now people are recognizing and realizing, but the people don't realize that the small babies do survive and also be able to do everything as any other child in future as well.
So I remember one question one of the preterm mother asked me. Actually, frankly speaking, sir, when we talk about premature delivery to the mother, we feel very relieved when the neonatologist walks into the labor room and talks to them, because it's not a one-side story that the obstetrician tells that I need to deliver you now and I'm going to deliver you. She'll definitely be in shock.
Absolutely.
So like a teamwork, when you come and talk to them, when we talk, that's when they understand that, okay, fine, we are going to take it as a team forward. But when you say that we are going to deliver it prematurity, sometimes there is a question always coming into the mind saying that, okay, preterm babies have lot of disabilities. I remember this question from the preterm mother saying that preterm babies get diabetes very commonly or cancer very commonly. So how is it, sir? How do you go about that question?
So our outcomes, rainbow outcomes for extremely low birth, which is less than 1 kilo babies, is in par with any international standard. Like
Okay, that's good to know.
so yeah, 70%. But again, as the babies born, we also come to know which babies are going to make, which we don't. And when we talk about, I mean, like a 700 grammer, 800 grammer, I don't want to say 100%, but it's like 80 to 90%. And even that 70% of not outcomes are more towards the 500, 600. But having said that, we have sent, that we have sent so many small babies home, like
True,
600
sir.
grams,
We have
500
this
grams,
premature
700
day
grams.
also.
And yeah. So one of the largest pool of premature babies which have been discharged in the country is from Rainbow Group. And some of them are going to school. But again, this journey is not easy.
Yes, sir.
So we need to help the families to understand this is a journey which is tough, but there are families who've gone through this journey.
Yes.
Okay, and we need to work in partnership with them, and so taking the parents throughout the journey along with us and helping to understand what then we need to be open and transparent about how they are, what is going to be. So if I mean sometimes we at times we are also were wrong in the sense that oh this baby may not do well, actually did well.
Okay.
So, but again, there are certain things to some extent we can tell. I'm talking about very small babies. So, I mean, well, the prematurity is the biggest problem in the world.
Yes.
And you could argue India is one of the capital for prematurity,
That's true.
unfortunately. And, but how can we prevent this? One of the questions, can we prevent the prematurity? Can we not to have a premature birth at all?
Many times the pediatricians refer back the mother in the interval period, like they would have taken care of a preterm baby earlier. So the pediatricians do refer those mothers back to us before they plan their second pregnancy to make sure that they don't end up in a preterm again. As we know, sometimes, I mean, most of the times we try to prevent the premature birth, but these are all high-risk women who have had earlier premature birth. So they have more than 50% chance that they may have prematurity birth again. So what we do is, sir, if they can come before they plan the next pregnancy, we try to screen them well for the infections. There is a saying that even a small dental caries or a tooth infection can lead to preterm pains.
Agreed.
So these all can be managed well before the pregnancy is planned. So when they come to us, we do the urine culture testing, vaginal swabs. Then we ask them to get a routine blood pictures done to see any other infection is there. First time mothers getting preterm birth, mostly it's related to their pregnancy factors, like sometimes vaginal bleeding throughout the pregnancy. In the early weeks, they may end up into a preterm birth. So we try to treat that very aggressively in the beginning itself. IVF pregnancies, Sir, actually once we deliver the pregnant woman prematurely for a known indication and necessity, then our job ends there. So the whole attention shifts to the NICU side.
That's right.
So how do you manage those small tiny babies and lot of attenders, like 50 to 100 of them waiting outside for you to say how is the baby doing inside now?
It's not easy. So our jobs begins when your job ends, as you rightly said. And I think it's important to counsel them on regular basis and make them to understand that is a long journey and depending upon how premature the baby is, and also usually what we tell them that there will be lots of ups and downs in this journey.
True, it's a long journey.
Yeah. So when you make them what is anticipated, they may get calm to some extent. But having said that, it goes in circles. So you tell them and they ask same question, then you get tell, and sometimes you just need to listen to them, as you probably do in your counseling as well. And we do at least 2 counselings per day, at least in the initial initial days, later on at least once, and again in between as required. And also they get the counseling from the team around in the NICU as they go along. And this is lot more counseling than what I would have done in UK or New Zealand. It's a lot more counseling. There's a lot of research from the Western world about the various emotional difficulties these families go through, and where there's a premature birth in the family. This sense of protecting the mother, not allowing to information is not quite right.
Yes.
I think she has every right to know, and as a father and any family members, you could actually argue maybe the extended family does not have the right fully.
Most of the families, what we see, sir, once we talk to them, like how you said you involve the whole family, once we also start talking to them saying mother is fine now, like by second post delivery day, she's good to walk, she's good to take care of herself. So she can as well walk herself to the NICU,
Correct.
see the baby. That emotional bonding is very, very important
Absolutely.
to get good breast milk and also to keep her in good spirits. I
Correct.
mean, sometimes the family who are saying her not to move or not to go, we are there to tell them that, you know, it's okay, let her go and see the baby.
We encourage these mothers to come in the wheelchair and see their baby, and sometimes she can just touch the baby, not necessarily in the immediately after the delivery. Yeah, and
I think here that in utero transfer helps a lot, I think, sir. So when there is this extreme prematurity, below 28 weeks mothers who are in a tertiary far off place, instead of delivering the mother there and sending the baby to the tertiary care for the baby care, it will be very good if they can send the mother.
Absolutely.
And then we deliver her here so that the mother and baby are in the same place and she gets to see the baby every day, every hour in fact.
Yeah.
And I think our NICU allows mother to come anytime into the NICU to see the baby and touch the baby and be there. So this would give a very good outcome for the both of them, for mother and baby.
Absolutely, I totally agree, and the research is very clear on that. The best place, the best way to transfer a premature baby is the mother's womb.
Okay.
So wherever, I know sometimes the situation may not permit, may not allow, but wherever possible, so always our healthcare professional should think, can I send this mother to the right place, in the right way, at right time? So like to the perinatal center. So where the baby and mother can be looked after, especially we are talking about the prematurity. So depending upon the level of prematurity, extreme prematurity, level 3 unit, what we call, and a moderately premature, maybe level 2, and so on. So the outcomes are very different. It's very clear across the globe. There's not much data from India, but in all the Western studies, it's very clear that if it's a no-brainer anyway. So it's, if you transfer unless if you can't, mother is too sick to transfer or the delivery is happening. Those situations
then
we can't
cannot avoid, but
wherever possible, correct. Wherever possible, we need to transfer these mothers in utero with the babies inside so that we can give best to the babies.